I like to think of each patient as kind of like a puzzle, and you're with them the whole time. You're there for pre-transplant, cross-match, post-transplant. So all the testing we do is like a piece of that puzzle. And I do think that the expanded panel is like giving you another piece to help solve that.
Right now, the University Health HLA laboratory is really focused mostly on solid organ transplantation. We support a very robust adult and pediatric kidney transplant program, as well as the second largest living liver transplant program in the US. When we are assessing a case pre-transplant, looking for compatibility between a patient and a donor, or when we're looking post-transplant for donor-specific antibodies, it's a huge gap to tell your clinicians, I just can't look for that and there's nothing that I can do to help you, because I don't feel like that's actually the case. When we are looking to fill those gaps without reagents, we can analyze the data to see what we have on a base panel that's the most similar antigen on the panel. But it's not exactly the antigen. It's just antibody reactivity that may be similar. So it's an option, but it's not the most accurate option. We would much rather be able to characterize specifically the potential for antibody reactivity against a specific antigen.
We first started using the extended panel December 2020. Bridging the gap was somewhat complex. We didn't have as many specificities as the XPlex panel does now. So for example, we have our allele AO205. Beforehand on the expanded panel, we only could report an AO2. We had several AO2 alleles that we just had to report positives or negatives for every single one. Now that we have the AO205 on the extended panel, we can just report specifically AO205.
Using the expanded panel with our post-transplant specimens has helped us be able to really identify DSA instead of saying like potential or serological equivalent, because instead of saying, oh, we have this A2 and we have 4 alleles, now we have 9, and we can actually rule out certain DSAs using this panel.
Highly sensitized patients, it's very important to be accurate. You want to truly be able to say, there is or is not donor-specific antibody in this patient, rather than basing it on an imputation or a guess. I feel like with extended options in single antigen testing, we feel much more confident about the estimations in our immunologic risk assessments. The testing is done before the immunologic risk assessment has to be performed, so that when the time comes that a patient comes up for an offer, we don't have to scramble and do a bunch of additional tests in that moment and potentially delay transplantation because we have accurate data at hand.
The additional information that we have gained from using the extended panel has enabled us to improve our matching of donors to recipients. In a larger sense, we've been able to transplant more patients without the fear of rejection because we have that specificity there. We've also been able to cut down on unnecessary transplants because we can rule out those beforehand.